Greetings to all. Myself, Dr. Sadhana Mukhi, Associate Professor at Sanchiti Institute for Orthopaedics and Rehabilitation, College of Physiotherapy. Welcome to the classroom series of PhysioTV. Today, we are going to discuss an important topic, an important and exciting topic on clinical science and presentation in cerebral ataxia. Let's start with the presentation. Yeah. So before starting with the presentation, I would like you all to know that what is cerebellum. So cerebellum, as we all know, is a center for balance, center for coordination, and for movement. Okay. So anything, any abnormality in the cerebellum due to any neurological condition will cause abnormalities in all three sectors. That is, the movement will be affected, the coordination will be affected, and the balance will be affected. Let's dive in further into this topic. For our help today, a we have our friend who is diagnosed with a condition called ataxia. Now, why this picture says that I'm not drunk? I have a medical condition called ataxia because a person who has cerebral ataxia is going to show slurred speech, is going to be clumsy, is going to fall over and walk as if the person is drunk. That's why many people might mistook this as if the person is drunk, but the person has a condition called as cerebral ataxia. So clinical presentation in cerebral ataxia. As we all can see in the diagram, that we have a person walking on a tightrope and trying to maintain the balance. Okay, that is set a bell and up. That is maintaining the balance, the body's balance, the body's posture. Okay, here on the right hand side, we have the cerebellum divided according to the function, right? We can see it in different colors. We can see the green part as the brainstem. The yellow part is the spinocerebellum. The pink part is cerebrocerebellum. And the purple part is vestibulocerebellum. The yellow part, what is the function of the spinocerebellum? As the name suggests, it is going to regulate muscle tone, coordination of skill voluntary movement. Okay. The pink, the cerebrocerebellum or corticocerebellum, also called as, it is important in planning of movement, in modulation of any voluntary activity, and storage of procedural memories. Vestibulocerebellum, as the name suggests, maintenance of balance, control of eye movements. Okay, so we have three parts which are divided according to the function, that is spinocerebellum, cerebrocerebellum, and vestibulocerebellum. Now let's see what are the clinical presentations, what are the clinical signs in cerebral ataxia. As I'm saying cerebral ataxia, the first thing which we all should know is what is ataxia. So the Greek word, it is a Greek word which means lack of order. Okay. So lack of order in what? So there is going to be lack of order in movements. The movement is going to be, there is going to be disturbance in the movement. It is not going to be smooth, accurate, and coordinated. That's why in ataxia, the movements are clumsy and incoordinated. In our patients, what all movements, what are things we will be finding this ataxia? So ataxia can be seen in following areas. That is in eye movements. When we see in eye movements, we call it as nystagmus. In speech, in balance and gait, and the extremities. When we see in extremities, it is incoordinated movement, ataxia, tremors. The next sign that we are going to see is dysmetria. Okay, as the name says, dys means which is not regulated. Metria, something related to meter, something related to distance. Okay, so what is affected in this? So there is lack of accuracy in movement distance. The parameters that can be affected are speed, range of motion, and the duration. So limb dysmetria can be defined as lack of accuracy in movement distance. Okay. Now on the right side, you can see in the video that the therapist is telling the patient to try to put the cap back on the pen, and the patient is struggling to put the cap back on the pen. Sometimes the patient is stopping before, okay, even while touching the nose, reaching at the side of the nose, not reaching accurately at the tip of the nose. Okay. So this dysmetria can be classified into two types, that is hypermetria or hypometria. Hypermetria is overshoot of an aim target during voluntary movement. So if a person wants to reach to a particular target, and if the person's hand goes beyond that, then it is hypermetria, that is overshooting. And hypometria is undershoot or premature arrest before the target. So if at all a person is trying to reach for a target, for example, picking up a glass of water, and the person stops before that, that is hypometria. Okay, so what mechanism exactly is affected in this? The feed forward mechanism of the body is affected in dysmetria. Okay, let's dive into the next clinical sign, that is our tremors. Okay, the tremors in this, as you can see, what is tremor? Tremor is involuntary movement of the limbs. Now, this involuntary movement of the limbs can be seen at two instances. Okay, you can see at the right side, there are two instances over here. The first that is written is the intention tremor. As the name says, intention. Intention means whenever a person intends to do any movement. Okay, so that's why intention tremor is seen during voluntary movement. Okay, and how is it seen? As rhythmic, alternating, and oscillatory movement. So here in the video, you all can see that the person is trying to reach the apple. As the hand comes closer to the apple, the tremor is going to increase. So occurs when you reach for something and your hand starts shaking. The next is postural tremor. So postural tremor occurs when a person tries to hold the limb against a certain position, especially against gravity. Okay, so here, how do we check this in a patient? So here you tell the patients to hold the hands against the gravity and the hands will start shaking. So postural or static tremors while maintaining posture can be seen. Okay, here in tremors, the mechanism that is impaired is the impaired feedback mechanism. Okay, we saw that in dysmetria, the feed forward mechanism was impaired. Now, a quick way, how are we going to assess dysmetria in our patient is, the routine test for this is the non-equilibrium testing. Okay, you tell the patient to do the finger to nose test, okay, for the upper limb. For the lower limb, you can tell the patient to do heel to shin test, and you can see the dysmetry over there. For tremors, intention tremor, you tell our patients to reach for an object and you will see increase in the tremors. For postural tremor, you just tell the patients to hold the limb against gravity in a static position and the postural tremor starts setting in. Okay. Let's go to the next sign, that is dysdiadochokinesia. Okay. Now, what is this? This is inability to perform rapid alternating movements. Okay. Rapid alternating movements. Now, which are these movements? They can be pronation or supination or any rotatory movement. Okay. As here, if you see the patient in the video, the patient is trying to pronate and supinate the arm, and it is much slower on the affected side. In normal human beings, the hand can easily pronate and supinate at various speeds, at a slower speed, at a faster speed. But over here, in cerebral ataxia, the speed is affected, the accuracy is affected, okay, and the person cannot do alternating rapid movements. Why do we see dysdiadochokinesia in our patients? Because there is poor regulation of timing of cessation of agonist muscle activity and initiation of the antagonist muscle activity. So, for example, if I intend to do pronation and supination, when I'm pronating, from pronation to supination, when I'm going, my pronators needs to stop firing and my supinators need to start firing. Okay, but because the timing of this two is affected, in our patients we are going to see dysdiadochokinesia. The other way to assess dysdiadochokinesia is you keep the hand, you tell the patient to keep hand on the legs and you just tell them to tap on the thighs. Okay, tapping the hand on the thighs and you will both the hands simultaneously, you will see that the affected side is slower and the accuracy is also affected. Other you can tell the patient to do is rapid closing and opening of the fist on both the sides. And here also you can observe dysdiadochokinesia. So the reason for it is poor regulation of the timing of the muscles. Okay, that the muscles that are active needs to stop firing and the muscles who are going to be active needs to start firing. The next cerebral sign that we are going to see is rebound phenomena. Okay, as the name suggests, rebound means something that is going to come back. Okay, now what is going to come back and why, how do we see this in our cerebellar patients? Okay, you can see over here on the right side that the ball is going down, coming up, going down and coming up. Okay, this is something that you're going to see similar thing in the patient's limbs. Okay, now let's see what is that. So normally when we resist any isometric, give resistance to isometric contraction, and when it is suddenly removed, okay, for example, you tell the patient to do biceps, the activity of biceps, elbow flexion, you give isometric contraction to elbow flexion and you suddenly remove that. So what is going to happen is normally the limb is going to stay in the same position. Okay, when the muscles in a normal patient, why? Because in a normal person, because of the contraction of the antagonist muscle. So if at all I'm resisting elbow flexion in a normal person and I remove the resistance, as you can see, the limb is going to just stay in the same position because my triceps are contracting so that it doesn't cause the sudden elbow flexion. But what happens in our patients with cerebellar ataxia? So in cerebellar ataxia, we see this rebound phenomena. That is, you tell the patient to do elbow flexion, that is flexion of the forearm against resistance. It is a strong isometric resistance that you're going to give. And you suddenly release the resistance. Okay, when the resistance is suddenly released, it causes hand to strike the face. Why? Because there is no check mechanism by the triceps. Okay, you can see over here in this video, the person is, the therapist is resisting elbow shoulder flexion. Okay, and when the resistance is suddenly removed, the hand can be seen rebounding into flexion and extension. Okay, see, you can see on the normal side and you can see on the affected side. The normal side stays at the same place, but the affected side moves into flexion and extension. So this is called as the rebound phenomena. Again, because of loss of check mechanism by the opposite muscle, by the antagonist muscle. Okay. So right now, what all did we see? We saw something called as rebound phenomena. We saw dysdiadochokinesia, we saw tremors, and we saw dysmetria. So all of these findings, that is our dysmetria, our tremors, dysdiadochokinesia, and rebound phenomena, they are all nothing but ataxia of the extremities. Okay, they are ataxia of the extremities, which we already saw in our first slide over here. That ataxia can be seen in the extremities. Now let's go to the next clinical presentation, that is nystagmus. So nystagmus is what? Normally, if you move your eyes side to side, up and down, the eyes are not going to oscillate. But nystagmus, there is going to be rhythmic, involuntary, and oscillatory motion of the eye. As you can see in the diagram over here, in the video over here, the eyes are oscillating to and fro when it is going at the side. Okay. When do we see this? We see this in the lesions of flocculonodular lobe, usually cause nystagmus. And as we can see, as the eyes are going into the laterally, so the nystagmus is present. So evoked by lateral gaze. Okay, evoked by lateral gaze. So what is this nystagmus that we are seeing? Again, this is ataxia of the eye movements. Okay. Let's come to another clinical sign of our cerebellar ataxic patients, that is hypotonia. Normally, we have a normal tone in the body, but cerebellar patients, the cerebellum, we see reduced muscle tone when the cerebellum is affected. Now, why do we see this reduced muscle tone? Because there is reduced proprioceptive information to the muscle spindles, or there is loss of facilitation from the cerebellar nuclei. Okay, we have cerebellar nuclei, dentate nuclei, fastigial nuclei. Now, when this nuclei, the reduced firing is there in this nuclei to the muscles, we are going to see reduced muscle tone. Also, our muscles are simultaneously getting some proprioceptive information also. Now, this proprioceptive information to the muscle spindles gets also affected in the cerebellar patients. That's why both these things contribute to hypotonia. Okay. Now, this hypotonia you can see as a generalized weakness, which is also called as asthenia, and it is also more prominent in the proximal muscles. Okay, so you're going to see the girdle muscles, the shoulder girdle, the pelvic girdle muscles to be affected the most, and more in the upper limb. Okay, now because of this hypotonia, as we saw initially, that how are our patients, they're slow, they're clumsy. So because of this generalized weakness or generalized reduction in the tone, the movements are going to be slow and the movements are going to be clumsy. Okay. Now, how do we also, because of this hypotonia, what else can be seen? We are going to, when we are going to do reflex testing our patients, especially the deep tendon reflexes, when we go for the knee jerk, normally what happens is we strike at the patellar tendon and we are going to get knee extension. Okay. In cerebellar patient, because of this hypotonia, we are, whenever we go for the pendular knee, whenever we go for the knee jerk, the knee is going to oscillate to and fro slightly. Okay, that is, it will go in extension, then flexion, extension, then flexion. Okay, and the knee is going to, the leg is going to oscillate as a pendulum. Now, why do we see this pendular movement during this knee jerk? Because normally when we tap at the patellar tendon, the quadriceps, the tone of the quadriceps causes the knee to go in extension. Okay. But as we saw that there is hypotonia. So when the limb is going down, it doesn't let the limb to go down slowly. Because of the weight of the limb and the reduced muscle tone in the quadriceps, the knee keeps on oscillating. That's why pendular knee jerk. So we saw ataxia of extremities, we saw ataxia of eye movement, okay? We saw hypotonia so far. The next thing that we are going to see is dysarthria, that is ataxia in the speech, okay? So what are the signs and symptoms in speech that we are going to see? The cerebellar ataxic patient's speech is also called as a hot potato speech. Okay, they talk as if there is hot potato in their mouth, or it is also called as staccato speech. Now, what all things are affected in them? So they are not able to speak louder, inability to speak louder. Okay, then abnormal speech rhythm is there. The voice is nasal sounding and there is a monotonous speech. Okay, so there's no voice modulation. Then even speech volume, sometimes it is low, sometimes it is high. It can be slow or slurred that you cannot understand. Then sometimes the speech is also rapid. So as we saw that there is ataxia, so there is no control. Sometimes it can be slow, sometimes it can be rapid. And there is difficulty in moving the facial muscles or the tongue. Okay. So dysarthria, we are going to see changes in the volume. We are going to see changes in the tone. We are going to see changes in the rhythm. We are going to be having speech that is a lot of strained and nasal sounding. Okay. So this is our dysarthria. That is speech abnormality in our ataxic patient, which is also called as hot potato speech or a staccato speech. And the last one that we are going to see is postural instability and ataxic gait. Okay, as we saw when we saw the first diagram, that is this. What did we see is we saw the person holding this, maintaining balance, and over here the functional classification of cerebellum. We saw the vestibulocerebellum causing maintenance of balance and posture. Okay, so when the ataxia affects the postural muscle, there is going to be postural sway. Okay, ataxic patients are not able to stand steady even with the eyes open or eyes closed. Okay, they are constantly swaying. Because of this, their balance is affected. Now, when the postural instability is there, the balance, both the static and dynamic balance is affected. Okay, that's why the patients are highly unsteady. Okay, we have to be very careful when we are treating the ataxic patients. The next, because of this, we are going to see something called as ataxic gait. Now, ataxic gait is abnormally wide-based gait. As you can see over here in the video that is playing, you can see the base of support is very wide. You can see the ataxic patient walking with a person's assistance. Okay, the base of support between the 2 feet is very wide. Then the gait is very unsteady. Okay, you will see clearly that it is not a steady gait. If at all the assistance is left, the person might just fall. And here, when the person is walking, you can see irregular step length. So sometimes the step length is larger, sometimes the step length is smaller. So there's a lot of irregularity. Okay, and so there is irregular stepping both in direction and distance. Okay. Then there is going to be reduced stride length because of this and reduced cadence as there is going to be a lot of postural instability during walking. So the cadence is also going to get reduced. So ataxic gait is wide-based gait, which is unsteady, which is irregular. Stepping is there. You can see the extremity sometimes going into hyperextension to maintain that balance. Okay. And cadence is reduced. The ataxic patients, they rely a lot on visual cues as their balance is affected. Okay. So you can see over here the patient walking, the patient walks while looking down. Okay. The moment they remove the vision, they feel very unsteady. So they use a lot of visual cues. So this is about our ataxic. As we saw the first picture also, that the ataxic patient looks as if they are drunk. When they walk, they look as if they are drunk. Okay, we can very well appreciate in this video. So a quick recap going to before ending this presentation is ataxia that is there in a patient. Okay, so the movements are incoordinated. As the movements are incoordinated, what is affected? Its accuracy, its coordination, and its smoothness. Okay, that's why the movements are going to be clumsy and there is going to be lack of order. We can see ataxia in eye movements. We saw nystagmus, rapid alternating movements of the eyes. Okay. So ataxia is lateral gaze evoked over here. Speech, we saw slurred speech is there, dysarthria is there. The speech is also called as hot potato speech or staccato speech. Okay, we saw balance and gait abnormalities, so postural instability is there, ataxic gait is the what we are going to see in our ataxic patients. Then we can also see the extremities to be affected with ataxia. So we see dysmetria, dysdiadochokinesia, tremors. Okay, all these things are seen in our ataxic patients and hypotonia. Thank you so much. And we are done with the clinical signs and presentation in cerebellar ataxia. I hope you liked this video and I would like to thank the technical team of PhysioTV Classroom. I would like to thank Apurva Sir, Principal SIOR COP and Manisha Ma'am to give us this opportunity. And once again, thank you SIOR COP for this opportunity. Stay tuned for more videos. Thank you.